I'm Jessica Diettrich. I am a senior program manager with Providence St. Joseph Health in, well, the Western US, but I'm in Eastern Washington.
And I'm Curtis McEntire. I am president of the Mazree team. We focus on asset recovery for hospitals and health systems. We're based out of Salt Lake City, Utah.
All right. So we want to talk to you today about how to maximize the value of your retired assets. As I say, Providence St. Joseph Health, we are a nonprofit Catholic healthcare system. We have 55 hospitals, more than 800 clinics and non-acute facilities. We're over 100,000 caregivers, and we're located kind of all over the Western US. And I don't know about the size of your guys' healthcare systems, but we buy a lot of equipment. You know, probably not as much as we need, but you know, that's kind of the state of healthcare finance as it is. And one of the things that we have run into is that we didn't used to know how to manage our assets. And we've decided that every healthcare system, no matter your size, whether you're 2 hospitals, 55, biggest system in the country, everybody needs an asset recovery system.
And maybe just to chime in here a little bit. So I used to work at Intermountain Healthcare out of Utah. And for years we had 22 hospitals, and for years we didn't have any type of asset recovery program. We talk about asset recovery, it's that end of life, like what's happening to the equipment when it hits its end of life. And most of the time it was like each hospital just kind of doing their own thing, right? It's things grow legs, they walk out the door. There's got plenty of stories we'll probably share through this, but I think I see that more and more as I work with different hospital systems across the country is, do you have a centralized program within your health system for managing this equipment? So it's just, I mean, there's value in it. Like, number one, it shouldn't be ending up in a landfill, right? Like, and maybe there's other facilities within your health system that could use it. Maybe you're like, I don't need it anymore, but I have other hospitals in my health system that could use it. And so, or it could be sold. And there's buyers all around the world that's willing to pay money for this equipment and compete for it and bid against it. And so really, if you kind of think about it as she's talking about, like every health system having something, think of your current health system and what is your program for any of your retired assets? Like, do you have a process and is it standardized across the system? So you're either redeploying the equipment, you're selling the equipment, or you're recycling the equipment, because the goal really should be nothing ending up in a landfill. Like there's really no reason for it to end up in a landfill. So sorry, Jessica. Yeah.
So as Curtis said, you know, we've got healthcare systems have thousands of assets that are being retired every year, whether they're being replaced by new technology, whether they're just failing, you know, these things are being retired every year. And so we know that they're taking up limited space. Who in here has enough space, storage space in your facilities? Anybody? I'm pretty sure that no architect that has ever designed a hospital ever consulted the actual caregivers or your teams as far as what we needed for storage space. So they're in closets, they're in storage rooms, they're in warehouses, they're in hallways. I know that my home hospital in Spokane, we have an entire shelf space on one floor that was originally supposed to be, you know, beds. We couldn't get the certificate of need. It is now a shelf space that is an entire 4th floor of antique medical equipment. Most of the stuff is older than I am, but nobody knows what to do with it. You know, you don't necessarily want to throw it away, or maybe we're going to need it for that one time for that one doctor who hasn't retired yet, but probably should have 20 years ago.
We just to chime in on a story here really fast. One of our clients, they had a space kind of like that. It just been building up dust, and equipment had been building up for years and years and years. So our team, you know, one of the things that we do is, like, as a partner, is we'll go in and just get all that equipment out, right? Like, let's just, and so we got all the equipment out. Our guys are like sweeping the floor and everything. And one of the biomed guys came and gave our guy a hug. And he's like, I haven't seen this floor in 13 years. And you think about it, like I was talking to a guy yesterday, St. Luke's, Carl from St. Luke's in Kansas City. And he said the same thing. He's like, our 7th floor of our hospital is just stuff that has just been there for years and years and years. And if you think about it, like think of inside your hospital, do you have one of those closets? Do you have one of those rooms? Do you have one of those floors? Or even a warehouse, right? Like even at Providence, they were paying thousands of dollars a month for this warehouse space just of stuff sitting there. And one of the things that we did is we brought 6 semi-trailers just to get it out, and it had been there for years and years and years. And a lot of it isn't worth anything. A lot of it just needed to be recycled, but they were just unnecessarily just paying all of these fees every month just for space when that equipment's just gathering dust.
Yeah, nobody has enough storage. If it's not in storage, it's probably in a landfill. We've estimated that over 37 million tons of medical waste is ending up in a landfill every year. Our hospital, our system has kind of a green healthcare initiative. I'm sure that most people do. That's something that's important to us anymore. It's like what can be recycled, what can be reused? How do we make this better? One of the things that we're running into is that with 55 hospitals and 800 plus clinics is that what one hospital might be great at getting rid of, another hospital might need, but there's not necessarily a centralized inventory. There's no way of sharing it. My hospital in California doesn't know that the hospital up in Alaska just got rid of a bunch of endoscopes and that, hey, we could use those. And so they're buying things that another hospital is getting rid of, and we didn't have to spend those dollars in the first place, but because the right hand's not talking to the left, we're spending money that we didn't need to spend and that we didn't really have in the first place. And then sales. I mean, I'm sure you guys run into that there are a few buyers that might reach out to your hospital, it tends to be doctor's offices or something like, oh, hey, we see you're getting rid of that microscope. We could use this in the ophthalmology office. Can we buy this from you? You're like, well, sure, that's great. It was going to be replaced anyway, but I don't know how much to charge you for it. I don't know how to get this legally off of my books in order to get this over to them. And then that means that you had a buyer that come and sought you out, but if you didn't have that buyer, what was going to happen to that microscope in the first place? And then what happens to those dollars afterwards? I've had physicians hand me a check for $10,000 for that microscope. And he's like, okay, here you go. I'm like, okay, what do I do with the check? Because who has a check anymore? And then it's calling up finance, and finance is like, well, I don't know, just mail it to this person. And you're like, okay. I mean, you're like, we got this revenue, but where did it end up? Does this actually mean anything? And can I spend that money later, or did it just go into this piggy bank of unknown dollars? I'm sorry, it's just sharing too much about my system. it feels very broken sometimes. And then finally, trade-ins. And I think that that's the way that most of us get rid of our current medical equipment right now. You're buying something new, maybe GE is going to give you $20,000 off if, you're trading in your CT machine. But you know that CT machine was worth more than that in the first place. But, GE's offering it to you, and that way you didn't have to go find a buyer. So we just go with the trade-in option. And then what's GE going to do with it? They're going to stick it in the landfill because they weren't going to sell it anyway. It's a 20-year-old CT. So over the last year, how many assets did you retire? Did you receive money for any of those assets? How many of them ended up in the landfill? And how many did you redeploy to other facilities? Can anybody answer that question in here? Excellent. Dwayne. Yeah.
What system are you with? Oh, nice. San Francisco? Oh, Oakland. Okay, sorry. Nice.
We actually have kind of a program that internally we sell assets.
Yeah.
We're talking about where the money goes. We have a sense of technology, the vision, and the money goes in there. And we usually reinvest into our technology initiatives.
Yeah.
Yeah, that's awesome.
Great.
It's really uncommon, honestly, to see like a built out program within a system. And because it takes, like, if you think about it, everybody's got so much on their plate, right? You think about your day job and everything you've got to do. Sometimes the last thing on your mind is like, what am I going to do with this retired stuff, right? Like from a list of priorities, it's probably usually down at the bottom. And so that's why it's like, I'll just go put it on the 7th floor, go put it in this closet, we'll figure it out sometime, and then it just builds up. And so to actually set the initiative and say, hey, this is a priority and have a program is really good.
We also have similar systems. Partner with a used equipment vendor to
Yeah.
manage those assets, and then obviously continue to keep the legacy assets in our CMS. So to answer your question, Jessica, I can ballpark it.
Yeah.
Yeah, that's awesome.
Sure.
Yeah.
Yeah.
Another supply chain services.
Mhm.
So my business partners are the directors of procurement, so that
Yeah, as new stuff's coming in, you can plan accordingly and.
focus on life cycle.
Right.
Design procurement life cycle of the business or redeployment.
Yeah, that's great.
So that's 2 health systems out of, what's probably 20 or so represented in this room today. So 10% being generous, that knows what they're doing. And that's fantastic. And I think that, leaders in that space are going to be showing up here. And so, we can say that probably less than 10% of health systems across the country know what's actually happening with their assets. So in 2018, Providence made a decision to partner with, an asset recovery program so that we could free up space, work on sending 0 pieces of medical equipment to the landfill, redeploy assets to our other facilities so everybody else could use them, maximize the value of our asset sales, and then provide an alternative to trade-in offers. How many people can recognize a room like that? And this honestly is probably an organized room. This is a very organized version of this. So we updated these numbers on Friday when I sent in the final presentation. But since 2018, we've seen over $5 million in auction sales of our equipment. We've deployed 329 assets, avoiding 1.8 million in cost of, in replacement costs. And then we've recycled over 38 tons of medical waste. And honestly, we're just cranking. If you look at our numbers from like 2018 to 2019, it was like a slow increase. And then 2021, 2022, it shot up. And so now that we've really kind of got our caregivers bought into this program, it just keeps getting better and better. So we've gone from this, you go from these, crowded storerooms to empty floor space, where your equipment is. One of the things that we've run into is, okay, so you partner with a company, you get rid of these assets, but you're like, well, what happened to them? Do you know what happened to them? What are they available for? Accounting's wondering what's, it takes the accounting issues from being held by the departments to, it happens behind the scenes now. The money goes back to the ministries. So rather than necessarily going back to each of your systems, and granted, that's going to be something that each of your systems sets up and how your finance teams choose to handle proceeds. But our money is going back to each location. If I pulled equipment out of Portland, that money's going back to Portland, whatever we sold it for. We don't handle any of the logistics. I have, our Mazree team, our driver shows up, we have a schedule. I know that he's going to be in Portland once every 2 months. And so our biomed teams all work together. If they see stuff laying around, they're gathering it together. So that when the driver shows up, we have everything ready to go. Right now, I'm in the middle of an anesthesia machine replacement down in Southern California. My first locations are going live at the end of April. And so as soon as I get my ship dates for those machines, I'm also reaching out to our Mazree team and saying, hey, like, anesthesia machines are bulky, or like my site's already stressing about having all these machines around. And it's a complete vendor switch, so it's not like we can hang on to them and use those parts for something else. And so I'm like, you know what, I've got this, we've got this machine, these machines coming in April. Can we make sure that there's a pickup, towards the beginning of May, that as soon as those machines are ready to go live in our system, that we're offloading our old machines, because that makes our caregivers' lives easier. And so with working with them, with our online portals, and we'll talk about kind of the analytics, because I'm a data nerd. I like to see the numbers. I like to see where everything's going. But we're able to see, what items were sold, what things are still in auction. If they just picked up a whole bunch of stuff from Portland, and I'm like, oh, you know what? I've got this request from Alaska. They need something. I'm like, okay, I see that we've got this stuff from Portland. It's in draft. It hasn't been loaded onto the portal yet. I call my other guy. I'm like, hey, we need this processor. Can you please load it up so that we can get it out there for redeployment? It's great. We've got testimonials from all of our BMET teams from across the whole system of what it has meant to them to have this program running and running well. It's made our clinical engineering teams so much happier, because they're getting rid of stuff that they didn't need to have on hand. We might hang on to some for parts if that's something that is going to make a difference. But otherwise, we're getting rid of it. And it's going to places that need them. It's being recycled. It's not going into the trash. They're very content with this. All right. So what does redeployment look like? What does that look like for, what does that look like for you? What does that look like for us? because redeployment isn't going to happen if it's hard to do. If that's, if that's on one hospital trying to pack up something and ship it off to another, it's not happening. Things are not being properly packaged. Things are being broken in shipping. It's just, and how does that hospital know what we have? What Mazree has set up for us is that we have this asset redeployment portal. And so up here, you can see the little bell with the cross sign there is a notification thing. And so let's say that your hospital needs anesthesia machines or you need endoscopes or something like that. You can sign up for notifications that anytime that something hits that redeployment portal, that it falls under those categories, you get this email and say, hey, guess what? Portland has anesthesia machines. If you need them, great. I mean, it is first come, first serve. So if you've got multiple people that are all looking for endoscopes or anesthesia machines, then you're going to fight them off as who can get in there fastest. But you don't have to go in and search every day to see what was the new uploads. For us, it's set up with easy staff access. Any caregiver that has one of our corporate email addresses can just load into the website. You don't need a password. It's not requesting access from somebody else. Anybody at Providence.org, you can just log into our website, see everything that's available, and they don't have to pay for it because the system's already paid for it one time. So if there's, we've got these like diagnostic cards, if that, was coming from, this one's down here, this one's at St. Patrick's in Missoula, Montana. And so if my hospital in Spokane needs that, they can just request it and it just gets sent over to them. There's just no hiccups. There's no friction there.
I think redeployment is definitely, I think one of those things can be one of the most challenging things within a health system because it is, you have to think of the logistics and you have to think of everything that kind of goes into it and then what's the value provided, right? So I've seen redeployment programs that, and maybe you guys have some of this where maybe it's because it doesn't have to be a tool like this, right? You could have an online share site, right? Where I've seen people, you'll just have a SharePoint site that you can post different things and people can see it and request it. So whatever it is, there has to be, I think, a commitment to it and then marketing towards it, right? Because you could be posting things, but if people aren't going to the site to check it out or they don't have some type of alerts, then it's just not going to work. So I think whatever tool that you do use is make it really easy and then market it, right? Promote it, and then you can kind of see the value that comes from it. But I think where I've seen redeployment programs just kind of fall is, it's not easy to use. People forget to even check there. There's no email alerts that go out. The logistics are a pain, all of that stuff. So if you're going to try a redeployment program, then I think you just kind of have to go through those boxes and say, are we equipped to do this? Is this something we want to do? And there's health systems, work with a lot of health systems. They're like, you know what, redeployment's just not, if it's not good, like, some perspectives are like, hey, if one of our hospitals doesn't want it, then I don't want it at any of our hospitals, right? That can be a perspective too. And so it can vary a little bit. But I think if you think about your own system and say, does redeployment make sense for us? If it does, it can be a really nice value add for the organization if you set it up the right way.
So how things are currently set up is that basically when something hits the redeployment portal for us, it stays there for 2 weeks. And so it's available for grabbing by any of our facilities for 2 weeks. If it doesn't get requested in that time frame, then it automatically moves into the resale process. And so it's not, again, there's no friction. We're not having to touch it. We're not having to say, hey, you know what, Tyson, this didn't sell, or this, nobody wants this. Can you just move it over to, can we sell it now? It just is automatically happening. But it gives them that 2-week window to go ahead and request the equipment that they might want. So 6 keys to success.
So I'll talk on the first one is there's really good partners out there. Mazree is one company, right? But you guys may use Relink Medical, Relink's a good group, Centurion, .med, like there are good groups all over the country that like look into, and sometimes it may need to be a partner that is localized to you, right? Because if you want them to do pickups, we're kind of in the West Coast, like we focus in the West. If you're on the East Coast, I'd probably refer you to somebody like maybe a Centurion or somebody else, depending on what you need, particularly if you need pickups. And so you might want to see who is the local partner or a partner that is equipped to support our facilities in our area. And there's a lot of good companies out there. I think when you think about when you're looking at different companies, obviously the people that you're interacting with, right? Are they contractors or are they actual employees and do they do a good job? You know, what technology are they using? What tools do they have? How automated is it? You know, are they sending the invoices on our behalf? Are they collecting payment? Like, are they doing a lot of the hard stuff on our behalf? I think that's what you want to see out of a partner. So you're not having to, I got to invoice them and I got to collect payment and I got to handle all of that. Like put it on your partner, right? Make sure they're doing that work for you. And then from a process standpoint, you know, do they fit in your process? Do they fit your needs? You know, and do you need pickups every 2 weeks, or do you just need a self-service tool where you can use a mobile app and just list right from your phone because you've got your own warehouse and you've got your own spot and everything else? And that's a, you know, a much more inexpensive option. So what services do you need? And then of course, price. I think most partners, they're gonna, if you think like how do they charge? I think most of you probably know if you work with one of these companies, it's either gonna be, you know, there'll be a commission on the sale or commission plus a pickup fee if you need the equipment picked up, or some of them do flat fee arrangements. So you can kind of, you know, depending on your health system and your health system needs. I think if you have your own warehouse and you have a resource that's dedicated to this, and you have maybe even your own couriers, I would definitely recommend a self-service model because you're gonna get so much more bang for your buck. Providence, in their case, they're spread across so many states, so having a central warehouse just doesn't make a ton of sense. But if you're regionalized and you have kind of a central space and you could hire a resource just to manage this, I mean, instead of having to pay a company like 55% commission plus a pickup fee or whatever you're being charged, you might be able to say, I can list this, you know, and pay a 10% commission fee and I keep 90%. And the money can add up really, really quickly, and your return on the investment of the resource and the space is easily paid for. You can get a really nice ROI. So it is something you could consider. But again, when you're looking at partners, you know, I think these are all great considerations. And again, like DotMed, Centurion, Relink, those are, you know, some of the top names that come to mind. There are others out there too, so you can kind of look in your area. And if you know, if you need help and maybe we're not in an area to support, you know, doing pickups or something, we can find companies that we can help refer you to somebody that would be a good resource.
I think the second step in being successful is the communication, but also getting your clinician support. I mean, this program would not run without the support of our biomed teams. You guys, they are the eyes on all of the assets, especially as they are replacing them. And honestly, they're the ones that are responsible for dealing with them after they've been replaced. As a caregiver, I just want the microscope gone. I really don't care where it ended up. And so when we were getting this kind of program up and going, our biomed teams were involved in the initial kind of decision-making factors and in our choice of a vendor. But also each of our departments has signs up, you know, on their bulletin boards in the departments of, you know, who to contact, how to get rid of these things, who our internal contact people are. We did site meetings at all of the hospitals just to make sure that they could have eyes on our partners, that we could really, you know, function as a team, and it's not just one more thing that's coming down from the system that somebody else is going to have to pay attention to, because they love that, as I'm sure you're all aware. And so we have a space on our, you know, on our hospital intranet that talks about asset disposal. It's always, you know, it's my website to update, so. You know, we keep it up to date. It's like they have the contact information for Mazree directly, but they also bug me. You know, if they need stuff picked up, if they're looking for things, they'll talk to me. They're going to email Tyson, because by now, you know, like Tyson's over, here's my redhead over here. We've developed these relationships that, you know, our biomed teams are very familiar with the Mazree team now. And so they're like, hey, we've got this thing. A lot of times I'm not even aware of things that are being picked up until I see it on the list afterwards. I'm like, oh, you know, we got rid of that. So we do have, our teams still have the same questions that you guys have had, like, oh, are we paying for this? How is this working? When is our pickups happening? And so we maintain kind of an information portal on the website. Again, they email me, but we also, like, I send out the reports because it's good for your teams to see what is the result of their efforts? And so if they know that by, Mazree picking up this stuff that, oh, by the way, we've acquired over 5 million in sold assets. We saved all this stuff out of the recycling portal or out of the landfill. This is really good information for your caregivers to have because sometimes it feels like we're making a difference. I worked in surgery originally. There is so much medical waste in surgery. It's astonishing the amount of paper and blue wraps and all this stuff that we throw away. And I think we all, we care about our environment. We hate seeing things thrown away, but sometimes it's inevitable. And so it's really meaningful for me, just even as a caregiver, to know that we're doing what we can to save all of this stuff from being thrown away. The other thing I'll say is that this is information that needs to be reiterated to your teams. I think that we try to kind of roadshow this with all of our clinical teams about once every 2 years or so, because there's turnover in your caregivers. And so maybe, that new manager doesn't know about, they don't know about Mazree. They don't know about the redeployment portal. They didn't know they could sign up for notifications. And so they've been stressing out trying to get those endoscopes that they desperately need when they were available to them. And so we try to go out and talk to our clinical teams once every couple of years and just remind them that this process is out there, that they can use it. It's free to them. And, eventually if they're getting rid of things, they might see some money, or, they're going to see some money back after they get sold. And it's worked well. I mean, we've been doing this for 4 years or so. And like I said, it takes a little while to get going, but we're really cranking, and I'm really proud of that.
Yeah, so you can see kind of the cranking. I'm a data geek like Jessica. And so having visibility to everything that's going out the door, I think should be a goal of every health system. And if you think, a quick story, one client that we brought on, as we were getting going, they started digging into some stuff that they thought was a little weird, where they kept seeing, the same person in their CMMS system, was the one who was disposing of the asset. And every time he would give it some weird number and then say it was thrown away in the trash and everything else. And then somebody actually spotted something on eBay, and they're like, that looks like ours. And then they started doing more research and found for years, he had been selling to a guy that would come to the warehouse. And this was a central warehouse, big health system, right? And there was a guy that would come to the warehouse, and he would say, hey, I'll give you, $5 grand for all this stuff, and give him cash. And then he would pocket the cash and then just say, have it. And then in the system, he'd mark it as that he had to throw it away or whatever else. And they tracked it down, and they tracked that it had been going on for at least 5 years, that he had just been pocketing cash and then just the assets just leaving the door. And it went through, the story of how he got caught, and, they pulled him into a meeting, and they had legal there, and they had HR there, and him, and essentially, kind of put him in a corner, or, they said, hey, we think something's going on. Have you been pocketing cash? No, I've never been doing anything like that. And then they showed him, this asset that was on eBay, and then they showed him this. They're like, you said you threw it away. And then he fessed up, right? Just completely confessed to the whole thing. And I've heard more stories like that, more than I thought, that there's just this, that's happening, because nobody's keeping an eye on it, right? And I get it, it's not the biggest priority, or, this asset's old, I don't care about it anymore, just get it out of my way. I think that's how we all feel a little bit. I worked at a hospital, and that's how I felt, is just get it out the door. And but at the same time, there's a responsibility that there should be a cradle to grave tracking of every asset that comes in the door, when it comes in and when it leaves and how it left, and that you have good tracking on it. And that's something that, as you think about your program, being able to have a report like this that says, for every asset that's been picked up, that's left, I can tell you whether it was sold, I can tell you whether it was recycled, I can tell you whether it was redeployed, all of that information in one place. And that's where we should be, right? We should be able to have a good handle on that, to avoid those kind of stories where you have somebody who's just pocketing cash, and the health system had no idea for years. I did follow up and asked if they decided to pursue charges, and they didn't want the negative press, it sounded like, so they're just like, you're gone, and go away quietly. But it was interesting. Yeah. Yeah.
So you've got retired assets, you can then go back to the finance and say, hey, we'll retire these assets.
Yeah, so there's a report that they get every month, and they can download it anytime too, but there's a report that says this asset with this asset ID left this hospital and there was sold on this date, it sold for this much, or it got transferred from this facility to this facility. And so it's one big report that goes over to finance and accounting so that they can do all the cost transfers and close it off the books if they need to. I don't know if you have
But
anything to add
the
to that.
vast majority of our equipment that is, going into this is fully depreciated because that's healthcare finance right now. We keep on making it work with, endoscopes that are 15 years old. This is something that our C-suites like to see, but honestly, this is something that the caregivers like to see too. And so we're able to break it down by, which facility has sent in, kind of all of their things. We don't have the listing details and kind of you can't see those screens right here, but you can see the asset listings are there in the middle, and then the auction sales are there on the right side. And so who else is running into supply chain issues with getting your pieces anything in the last 2 years? I think that is one of the things that's really playing into why we've done well in these last couple of years, is because literally you cannot find, an anesthesia machine to save life. Ventilators, nobody could find a ventilator for so long. And so this really, really helps with identifying, meeting your needs across the system, but also meeting needs of other healthcare systems, because other people need that equipment too. It shouldn't end up in the trash. So as we were saying, the way that our system is set up, and I'm not going to say that this is how every healthcare system will work, but how Providence has it set, is that the funds are directly going back to your locations. And so when I get the check once a quarter, I also get the report saying Portland, is getting, their sales accounted for 600,000 of this, and maybe Sacred Heart's 150 or something like that. So that check is going back directly to those ministries and saying, here you go. That makes a difference. I mean, our capital, yes, it's all system funded, but it is allocated by the locations, and those are precious dollars. Nobody has enough money right now. And so when we're able to, to send those back to the locations and say, yes, you're replaced, here's more money. Go out and get more equipment. Let's take care of our patients. How do we do this right?
And I think
It makes a big difference.
that does go into a lot of times why I think departments want to take the trade-in, right? Because they're like, well, if I sold it, I never see that money. And so they're like, I'd rather take the trade-in because the money's, then it's coming and it's helping fund my thing. And so when the facilities know that they're getting the money, and even if that money can even get back to the department level, the departments are going to be more bought in to participating, because and saying, all right, I'm less willing to take the trade-in because I know those funds are going to come back to my department. I know it's probably a little bit, you have to fight that fight with finance, but it's it's really, I think, for ultimate success, that helps a bunch if you can get the funds back to the department of that department that owned that asset or was responsible for that asset. So really, I think the other part is just make sure you have a consistent process. Figure out what your process is. And for a lot of clients, it's kind of like if it needs to be picked up, our responsibility is we pick up the asset, we take it to our warehouse, we prep it, we photograph it, we inventory it, we list it to the site, and then it stays in storage. It goes to the site and it stays on the redeployment portal for 14 days. If it doesn't get redeployed, it automatically drops to auction, and then it goes to auction, and it'll go through a couple rounds of auction. And if it doesn't get sold, then that's when it kicks off to recycling. And we know, okay, nobody wants this, let's just recycle it. And so, but having a consistent process, like figure out what your process is that makes sense for your health system with your partner that you've selected, your vendor, to say, how do we get the most value out of this? And that the other part is that our hospital sites, that each of the sites, they know the process, right? There's some consistency. Like Jessica said, like every one of the Providence ministries, you know, they know every other month they're getting a pickup. They kind of know, and they know the same people, and it's just become kind of second nature. I think if things are changing all the time, it's just hard for people to get behind it, because it's like, well, we were doing something different, you know, a month ago, now you changed it again. Like, as much as you can, drive consistency, and that'll help, you know, continue to get adoption of your asset recovery program.
And then kind of the last part we wanted to touch on is don't always take the trade-in. You know, it's easy. I mean, that's always when finance is wanting you to go back and get the lowest quote possible. You know, it's easy to take that trade-in option. But you know, if you've ever traded in your car, you know you could get more money for it if you were just going to resell it separately, but it's harder. It's a little bit more work. Mazree has enabled us to not have to go with their trade-in option, which my procurement team loves, because trade-ins are a hassle depending on how whoever your vendor that you're working with is. Trade-ins are a hassle because if they aren't just giving you, a line discount off of your quote, if it's going to be a credit, your procurement team absolutely hates you. They do. I'm sorry. I love you, but they absolutely hate this, because it's going back and trying to track those assets down to make sure that they get returned in the right amount of time, and that credit shows up so that their projects are not overdrawn. I'm running into this with ventilators. We bought a bunch of ventilators fortuitously at the end of 2019. But then when they were delivering in March of 2020, we talked to the company we purchased from. We're like, hey, yes, we just bought all these ventilators from you. Could we please hang on to all the ones that we were going to trade in? Can we hang on to them for a little while and see what this looks like? And here we are 3 years down the line, and I'm still trying to get the rest of those ventilators out, because our hospitals needed them. And that vendor was great in allowing us to keep them, but our hospitals needed those. And now I need them back, because I have 3-year-old projects that are completely blown up, that we've actually ended up having to pay those credits back on, because we never got those trade-ins back.
Sometimes the trade-ins are good. We'll have clients call us and say, hey, we've got an offer for this. We'll look at it based on what we see in our data. We'll say, actually, that's a great offer. I would take it. The only thing I would just recommend whenever your teams are getting trade-ins, they should first get a quote of the new equipment without the trade-in, then get a second quote with the trade-in, because then you'll know how much are they really valuing the trade-in. Because a lot of times, if you got that initial quote with the trade-in, a lot of times manufacturers want to hide their discounts in their trade-ins, right? They don't want the price that they're willing to give like out there, and so they'll hide that discount in the trade-in. So you really don't know what your real trade-in value was. And so I always recommend get a quote first without the trade-in, then do a second quote and say, hey, can you give me a second quote with the trade-in? Then you know how much they're really valuing it. And again, sometimes it can be good, and then other times it's like, yeah, no, we can do way better, on our own in the open market. So we have, and whoever partner you select or you guys use, they may have something similar. We have what's called a value estimator tool, where you can put in a model number, and it'll give essentially results of, here's every time this has been sold, and here's how much it's sold for. Here was the min price, the max price, the median price. So you get a really good idea of, okay, if I tried to sell this, how much would I probably get for it? So it's really nice to quickly bounce against, if you're looking at a trade-in for like a OEC 9800 C-arm or a 9900 or whatever, you could type that in and say, what are these selling for right now? And you can get a good idea. And that's helpful for just making quick decisions on, should I take the trade-in or should I go to the market? Which one am I going to do better at?
We've been in the middle of a 3-year-long endoscopy conversion for switching of our entire system. We've had a mixed vendor house for all of our locations for a very long time, because nobody tends to replace endoscopes in a full program. It's just, oh, you need a new colonoscope, you need a new EOS scope. Here, let me buy you these two with whoever your contracted vendor is at the time. but then that leads us into a place of having two, three vendors in our departments. And so we've been in the middle of this project for replacing our entire fleets, getting all of them onto our contracted vendor. And so this has really been a project that we've been really tight with Mazree on, because when you're getting rid of thousands of endoscopes, I get to be best friends with Tyson and Curtis here. When we're looking at what the, what the OEM trade-in value was on them, if we had gone with that, they were, probably offering in the neighborhood of 1.2 million for the value of the scopes that we have currently have in the system. And right now we're sitting at over 1.9 in 1.9 in sales for those same equipments. And I heard that Tuesday was a really good auction day for our scopes that, old towers that we aren't using anymore. Nobody in our system is using them. It was our old vendor. We've sent them in. Those were going for higher than what their retail price is. What that same vendor would have sold them to us new, they sold on Tuesday for higher than that. That makes us very happy, but it also, this takes the trade-ins out of the factor. And so even now, I mean, I'll email Tyson. I'm like, hey, what is, what are you guys seeing for anesthesia machines? Because I'm like, maybe this vendor is giving me, it seems like a decent trade-in price, but I'm like, what are you guys seeing for it? They're like, oh, this amount. I'm like, okay, well, I'm going to take the trade-in. Or, oh no, this is a real good deal. No trade-in. Thank you very much. Thank you for playing. So this has really put us into a good position of we have somebody to ask, because how many times you don't know if a trade-in was a good idea. You didn't have somebody to ask in the first place. You don't have that resource. I mean, we can look at eBay, but eBay doesn't mean anything because you're not actually trying to sell your thing on eBay. And so having a partner that we can ask these questions to has been incredibly valuable. All right, we don't have a slide for this, but I wanted to talk about donations just for a second. Healthcare systems, we like to donate our stuff. If there's somebody that's looking for it, maybe you work with a school, that is, they have their anesthesia program, they have an ultrasound program, you have this old ultrasound you're wanting to get rid of. How do you facilitate those things? There's all these legal standpoints of getting equipment off of your books, making sure that kind of all of your contracts, all your payments are wrapped up, there's no liability. It's not just as easy as saying, hey, yes, we are happy to, give this to you. Why don't you show up on Tuesday and roll it out to your car? Because your finance team is having kittens when they hear this. And so being able to partner with Mazree, even not just on sales, but to facilitate those donations. And it was like, how do we work this so that we can still, support our communities and be able to, give this equipment to them, but also, make sure that we are clearing ourselves from a liability standpoint and from a paperwork standpoint. And so we've gotten to a point where, I've got a facility over in Seattle that they wanted to donate their ultrasound equipment. Maybe it has market value, that's fine, but they as a department had decided that they wanted to donate it. We want to support our caregivers in making that happen. And so it's like, I'll email the information over to Tyson, be like, hey, we want to donate this to them. They create this listing for $1. And then that way, whoever they're donating it to, they still create their logins. They come in, they click the little box that releases us from any liability. They pay their $1 for that equipment, and then they can show up to the facility on Tuesday and go get that equipment. And by being able to do that, rather than just saying, no, we don't have a way of doing that, we don't do donations, everything goes to Mazree, that keeps your caregivers in a better place too. Because those people that you're donating those things to, maybe your caregivers in 2 years. So it's just another way that we can really impact our communities in a better way. So, questions?
Yeah.
Yes.
The nice thing is most medical equipment has a lot of metal, right? And metal recyclers love metal, and they'll even, it's not a lot of money, but they'll pay, we'll take a full truckload of just stuff that's a lot of metal, of equipment, drop it off. They weigh you when you go in, and then they weigh you when you go out, and then they, here's $150 kind of thing. So yeah, the only times that you have to be is if like refrigerators, are kind of a pain because of Freon. So there's certain places that only take that, and sometimes you have to pay to get those to the right locations. Obviously anything that's hazardous, you just can't take to a metal recycler. In some of those cases you have to pay, but the vast majority of equipment can just go to a metal recycler, and they actually pay you cash for it. They'll pay you some money, not a lot, but it is something. So it's not, it's not nothing you have to pay for necessarily.
Who is, I guess my question is, who is the gatekeeper? Who keeps, I guess from a biomed perspective, kind of the dog equipment that we didn't want to get rid of because it's not good, circulating back around and just going around the hospital?
Honestly, that's going to depend on location to location and kind of how, like I said, we're 55 hospitals. And so for us, each of our BMET teams they have a manager. And so I presume, I'm not going to say that I know this process completely from the ground level. But somebody, really, Mazree is just working with kind of our BMET managers. They are not working with every single clinician, because it just isn't always the greatest thing.
One of the processes we had to implement was if a clinician requested an item that was on the redeployment portal, we have the list of contacts of the biomed manager at that facility and say, hey, your clinician requested this, check out the listing, do you approve it? Because biomed's like, no, we're trying to get those out. I will tell them no, or they'll be like, actually, yes, we really need that, and that type of thing. And even if it's, a lot of it's like, oh, there's some cosmetic wear or whatever, but even if there's little tweaks, oh, I gotta fix this, no problem. But that's the process. If anything gets requested for redeployment, we're required to contact the biomed manager and get their thumbs up before sending it to that hospital.
Yeah.
One thing I would mention, we'll get asked this a lot, like, well, which equipment brings the most value? So just kind of think about it. Imaging equipment always does really well on the used market. So you're talking C-arms, ultrasounds, even some X-ray rooms. A lot of times when we run into X-ray rooms, they're pretty old, and then it's, you're just trying to find a company that will do it. And I would say this: number one, generally do not pay anybody to come take your equipment out. Most of them are willing to pay you for it and do the deinstall, right? So like if you got an MRI or a CT or an X-ray room, most of the time they will pay you and they will do the deinstall. If you're going to do it though, obviously you got to make sure that they have general liability insurance, and they're kind of following your guys's, so make sure you get their certificate of insurance, and that's not some guy showing up with his 2 sons in a pickup truck, like they got to be legit. And so, but like there are rare scenarios where I've ever seen that you need to pay somebody to deinstall something and take it. Most of the time they should be paying you, and they should be doing the deinstall. So there are situations though, like some old X-ray rooms or a really old CT or really old MR, like, okay, in some of those, but they have to be like 1998, right? For somebody like a 2005, a 2006, people will want those, and they will pay you money for them. When you're looking at, CTs, MRIs, a lot of times they want, the value is going to change a little bit depending on the tube and the scan seconds and everything. So you're just going to want to be able to provide that information. But imaging does really well. Endoscopy does really well. Hospital beds are a little bit of a dog just because they take up so much space. And so they're taking up a bunch of space for you, and then the person who's buying it, usually it's like they're trying to fit, in a semi truck, how many can they fit in, and they're trying to stack them and everything. But you're always, somebody's going to generally pay for your hospital beds as long as they're somewhat decent. Pumps, your infusion pumps, typically monitors, patient monitoring, all those do well. There's a lot of things that don't, you know, carts, just random stuff. And just some really, really old things that have just gotten so old that it's just like they need to go to recycling. And sometimes, like there's certain things we'll pick up. We go, this is not going to sell at auction. Nobody's going to want this at redeployment. It's just going to go straight to recycling. It's in really terrible shape or something like that. So in some cases, we'll just make that judgment call. But anyway, so if you think about your equipment, you know, yeah, don't let imaging equipment just walk out the door. Don't let endoscopy walk out the door. You can get really good money for that.